Hello. Hello.
Good evening,
Ah,
Rajagopal sir. How are you?
oh, fine. Just logged in. Will it take time?
No, sir. We are just going to start. Just waiting for other faculty members also, and we'll quickly start.
Oh, fine. Thank you.
So here you could see only the presenters. We have a separate room for all the audience where they have joined in. Just to call out, we had more than 30 registrations, and we have the audience also live with us. We will
Thank you.
just begin just checking in with Dr. Maruti. Maruti is here. Okay. Dr. Kapardhi. Just a sec. I'm just checking with Dr. Kapardhi once. So we have.
Ronak, somebody is joined as an iPhone name. Can you please check the
Oh, yes,
doctor's
yes.
name? Then we will rename.
No, it's me, Sakshi.
Sakshi. Okay.
Okay. So we have Colonel Dr. Nikhil Kumar sir also joining. Thank you, sir, for
Me
joining in.
joining.
Yeah, yeah. So we have Dr. Barua sir. We have Dr. Nikhil sir. Yeah, Dr. Rajagopal as well. I think we'll start. We'll check in the meanwhile for Dr. Kapadi to join in. So I'll quickly share my screen. We have as our moderator Dr. Dibya Kumar Barua. I'm just sharing my screen and then I'll quickly talk about our company and then we'll transfer this whole meeting to Dr. Barua. Just sharing my screen. Yeah, hope my screen is visible.
Yeah, we can see.
Yes.
Thank you. Okay, so thank you everyone for joining. We have in this open colloquium, we have our international faculty, Dr. Moaz El Sharabassi, who is the head of the Cath Lab, Chip and Structural Heart, interventional cardiologist at Contla Heart and Vascular Center at Elizabeth Hospital Essen from Germany. We have our moderator, Dr. D.K. Barwa, sir. He's a senior consultant cardiologist, Apollo Hospitals, Health City, Visakhapatnam. We have Colonel Dr. Nikhil Kumar, sir, who is the Senior Director, Cardiology, Fortis Memorial Research Institute, Gurugram, as our faculty for today. And then we also have Dr. Pilin Kapardi. Dr. Kapardi might join in some time. So he is a Senior Interventional Cardiologist and Clinical Director, Care Hospitals, Banjara Hills, Hyderabad. And then we have Dr. Rajagopal, who is the Chief Interventional Cardiologist at Awan BKG Hospital in Mysore. So on behalf of the Translumina team, I welcome all of you, sirs, to our open colloquium. And I also welcome all the delegates who have joined in. We are going to have a very intense and exciting discussion on OPN. So before we go there, I'll just quickly talk about our company, which is Translumina. So Translumina basically is the holding company. Integris is the holding company for Translumina. Translumina is a subsidiary here. Integris MedTech is divided into two different parts, which is Everlife and Translumina. So Everlife is into diagnostics. Translumina, as you all know, is into coronary angioplasty-based products. We have a diversified portfolio. We have cardiovascular, which is part of Translumina Group. Then you have in vitro diagnostics, scientific lab solutions, which is part of the Everlife Group. We are the leading market player in terms of lab solutions. We are largest Stent player in India, domestic wise, and we have a market share of 18% across all our stents. And our company is present in different geographies, so we have unparalleled market access, be it hospitals or cath labs, be it labs, be it distribution partners, um, and we have strong R&D and manufacturing across. In terms of products, we have polymer-free stents, we have advanced coronary DCBs, we have IVL, OPN as calcium modification devices. Then we have intravascular imaging, physiology solutions, and vascular accessories as part of our cardiovascular portfolio. In our Everlife portfolio, we have in vitro diagnostics, immunodiagnostics, clinical chemistry, hematology, lab solutions, more bigger part of the diagnostic arm that we have here. Then we have scientific lab solutions as well, which is antibodies, genomics, proteomics, etc. But we have great partnership with some of the leading players in coronary angioplasty like Shockwave Medical, Sys Medical, Kaneka, Assist, and so on and so forth. So we are actually present globally in most of the countries, primarily based out of India. We are present in Germany, Netherlands, um, and we have a well-diversified portfolio like we were talking about. Uh, Talking about the theme of products that we have. So starting from access, we have Asahi product line of products. We have Kaneka line of products and vascular accessories. Then we have SS, where our imaging portfolio comes in. We have Assist, HDI Assist Kodama, which is part of a larger imaging portfolio. And in the prepare, we are actually very deep. We have Shockwave Medical, IVL, we have Sys Medical, OPN balloons, we have Optima NC balloons as well. And in treat, we have our larger stent portfolio, which is a Yukon choice or Yukon range of portfolios, Vivo ISAR. And then we have our DCB, which is Protege, taken from post our acquisition of Blue Medical. We got Protege with us. And then in the FDA stent, we have Medinol, Elunid Pearl. So we have non-FDA, FDA stent, both mix as well as Protege DCB balloons. So with that, we come to our hero product, which is OPN. A lot of discussion would be done on this today. It's a fantastic product, probably a Swiss Army knife, which any senior operator needs in their cath lab. It has got a twin-walled balloon. It has got an RBP of 35 ATM, nominal pressure of 10 ATM, and a perfect lesion modification device with a proven efficiency in ISR and post-dilatation expansion. These are some of the features. Again, this will be talked about very deeply within the session that we are going to have. A short video about
when it comes to treating heavily calcified lesions in coronary artery disease, there is no room for error. That's why you need a reliable tool that you can trust. That's where OPN-NC comes in. US FDA approved and CE marked ultra-high pressure plaque modification device designed specifically for these.
Sorry. I lost the screen. Is my screen visible now?
No.
No.
Okay, I'll just try to reshare. I think we have already skipped 10 minutes. So I'll transfer this to Dr. Barua, sir. Sir, if you could
Yeah,
start the session from here with
I can
your
hear you.
presentation. Yeah. Can you hear me,
Yeah,
sir?
can you hear me?
Yeah. You're perfectly audible, sir. Although we cannot see you.
Because there's some issues in the camera, I think. I don't know what's happening. Not able to make out this.
No, not a problem, sir. Would you be able to
Yeah.
share your
He was
content
visible
with
earlier.
us?
He was visible
Yeah.
earlier.
So I'll share my this one.
Right, sir. So I'm handing over this session to you, so you can share your content. You can give your presentation, and then maybe after that, I would request you to call out different speakers along with their sessions. Is it fine, sir?
Yeah, 1 minute, please. I'm not able
Sure.
to share it. Something wrong here.
So we can see your screen well. We can see your screen.
Can you see the screen?
Yes, sir. It is perfectly visible.
Okay.
So you can begin, sir.
Yeah. Yeah. Good evening. Thank you, Ronak, and good evening to all international and national faculties, as well as doctors participating in this conclave of high pressure balloon, OPNC balloon. And thank you very much for giving me this opportunity. This is our experience. This was presented in TCT as well last year. Just want to show a few slides of that. This is basically we have done open NC balloon in a highly calcified kind of coronary condition where other balloon fails. That is the basic basic actually background is that calcified lesions limit. We know all of us is a stent expansion. And adequate lesion preparation and stent deployments are very important for optimal outcomes. As all of us know that calcium is one of the biggest challenge in cath lab, and that creates a lot of difficulties during the procedure, as well as even short and long term. A lot of complications can happen unless you do it properly. And we do have a lot of tools for the calcium modification. However, as a balloon, I think we have right now we have some compliant balloon, semi-compliant balloon, or this non-compliant balloon. And this is the kind of another addition to this basket is the open NC balloon. This balloon is a very high pressure balloon, and you can see the graph here. If you increase the pressure, the diameter doesn't change that much, even up to 40 atmosphere. So this is the beauty of this balloon. It is basically the double. I mean the dual coat balloon. These balloons have two layers, so that it can give a very high pressure and without it changing the diameter. This is which is required in a very kind of fibrocalcific lesions, so that we can go to high pressure without changing the diameter of the balloon. This is the advantage of this balloon. So this balloon actually we have used in cases, and our basically objective of our study was that to evaluate the safety and efficacy of the ultra high pressure balloon, OPNC balloon, in treating fibrocalcific coronary lesions during PCI. Our primary endpoints were successful lesion dilatation with a stent expansion, residual diastenosis less than 20%. And secondary endpoints with major CV complications as well as device failure. And now what is the method? It is a retrospective. Basically, we have just kept all the data of these cases, single center and observational study. And during 2022 to 2025, there is a sample size of 268 lesion in 262 patient. what is the inclusion criteria of where other balloon fail conventional NC balloon to dilate the lesions. This is the basically the inclusion criteria. Indications, plaque preparation prior to stenting, 88 lesions we have. Post dilatation after stent under expansion, for under a stent and under expansion 124 lesions, and treatment of instant restenosis 48 lesions, and both preparation as well as post dilatation 8 lesions. What is our kind of methodology? Methodology: calcified lesions. If you get a balloon crosses, fine, we can go for semi-compliant balloon. If not crosses, we go to atherectomy. And semi-compliant balloon, suppose waist disappears, fine. In two orthogonal, usually what we do in two orthogonal, we will check it in a calcified lesions. Suppose it is a non-compliant or semi-compliant balloon. Suppose waist disappears, that's fine. And you can go for kind of stenting or DCB, whatever it is. Suppose waist doesn't disappear, then this is the opinion. So these are a group of patients where non-compliant or semi-compliant balloon could not dilate the lesions, and we had to go for open NC. How we selected the balloon? Usually for the pre-dilatation, we have taken a 0.5 millimeter less of the reference vessel diameter, and we this is a normal methodology that you inflate slowly at least 2 atmosphere at a time, and after 20, once you reach the 20 atmosphere. So after 20 or 22 atmosphere, you should inflate the balloon little slowly rather than very rapidly. So once it is done, then after stent implantation, usually we took a balloon of 1:1. So pre-dilatation, we take 0.5 millimeter less, and post-dilatation, 1:1 stent diameter. So this is our methodology. And patient profile, we have mean age of 65. Male is 79% male. Hypertension, diabetes, these are all normal kind of risk factor for Indian patient. 76%, diabetes 70%. Prior PCI in 48%, as we told you, those are ISR, and prior COPD 14 patients. And clinical present, the majority of the patients are actually acute coronary syndrome. You can see the acute myocardial infarction is almost 38%. You can see here stable angina 31% and unstable angina 31%. So both myocardial infarction and combined together with unstable angina, majority of the patients were in acute coronary syndrome. Angiographic characteristic, culprit lesion, majority of the case in the LAD. You can see the major chunk of the patient in the LAD, and RCA 55%, circumflex 55 patient, circumflex 29, left main 5, and SVG 2 patients. Calcification adjunctive therapy, what we did, all cases is a moderate to severe calcifications. At least all of have the moderate calcification, and severe calcification, we have 44 cases, and we had an IVL used in 26, rota in 16, and orbital atherectomy 2 cases. And this is one case, as you know, these are mostly very old patients who come with heavily calcified lesions. This is an 84-year-old hypertensive diabetic who had, in fact, he had actually primary PCI to LAD. He came with unstable angina. You can see the very heavily calcified lesion. This is the stent in the LAD patent, proximal LAD and proximal circumflex are heavily calcified. And you can see this is the 3 millimeter IVL. You can see the waist here. Even IVL could not not enough to treat the lesions. There's a waist persistent waist was there. And after that, we have used the open NC balloon, 3 millimeter open NC balloon. You can see that at 32 atmosphere, 32 or 35 atmosphere, you can see open NC balloon waist disappear. So this is one of the important adjunct to the IVL or other tool, where one particular tool doesn't work, then open NC can be used to treat the lesion. Because post IVL and open NC, you can see the lesion open very well. And finally, we did a DK cross to the LAD as well as left main DK cross with good results. You can see the MSC is very good. If you see the highlights, the previous this OCT before prior to the lesion, you can see the nodular lesions, double nodular lesions in this circumflex. Even LAD also have a heavy chunk of lesions. So this is one case we use open NC as a adjunctive therapy to IVL. This is another case, again 86-year-old man who underwent PCI to left main ostium actually left main. He came with restenosis. You can see that here. This is the very tight restenosis. Here the LV of 35%, basically presented with kind of acute pulmonary edema. You can see the IVAS shows the calcium nodule in the left main. So probably that is the reason he came very fast after 4 months of first PTC. He came back with a restenosis, and there is a calcium nodular calcium. You can see there. So this we have used this NC balloon, 3.5 NC balloon. We tried to open these lesions. You can see that at 22 atmosphere, but waste didn't give away. This still waste is there didn't. Then we have taken a 3.5 millimeter open NC balloon at 32 atmosphere. Sorry, 35 atmosphere. You can see that after 35 atmosphere, we have seen this kind of IVAS. There is definitely luminal gain. The luminal gain is there, but there is a calcium. Kind of junk of calcium, what we can say nodule, is there no fracture there. So we've gone to 40 atmosphere. You can see that after that there is some fracture is there. We saw some fracture in the calcium. Then that that after that I think we put a stent in this particular case, and here a good result. After this, you can see that we put a stent, and finally we have a good result after pot and all. You can see the good LED MSA as well as good left main MSA. Here are good results. So this case also another very kind of unique in the sense that there is a calcium nodule in a left main situation where there is a kind of severe LV dysfunction with a 86-year-old person, CABG, which is difficult to do in these kind of situations, and we could manage this nodular calcium using an open NC balloon, which is not very usual because there is no perfect treatment for calcium nodule. Now we use the IVL and orbital atherectomy. At that time, orbital atherectomy and not the IVL just came. So we use the open NC balloon to this calcium nodule. And more important thing is that unless you have IVAS or other imaging, unless we see that there is a fracture in the calcium nodule, it will not be easy to treat this kind of situation. So imaging is very, very important in this kind of situation. We have proved that there is a fracture in the calcium nodule, then only put a stent. This gentleman, he improved a lot, and he has been there for almost 2.5 years. Right now, he is doing very well. So this is another interesting case. You can see that there is a LED and a diagonal bifurcation. Here you can see heavily calcified lesions. There is a complex bifurcation, basically Medina 111. This diagonal disease, LED disease, and you can see the LED calcium and a diagonal calcium. You can see this the NC balloon at 20 atmosphere could not dilate the artery. So we had to go for a rota first, and after rota we had to go for open NC balloon to the diagonal. A diagonal can be open, although there is a chunk of calcium in the diagonal, but open NC balloon at 2.5 millimeter open NC balloon. I didn't go to very high pressure, but 32 atmosphere. Still, we have gone to 32 atmosphere, not to 35. It is open. Finally, we put a stent with a nano DK cross. Here, a good result. This lady, you can see that the result is very good, nicely open. You can see that even bifurcation stent is very nicely seen with a good luminal area of the diagonal bifurcations, and you can see the nicely reconstructed bifurcation. So open NC balloon are used in this case for the diagonal, and LED for the LED we have used the rotablation. So our results at 98%, 98.2% successful in our cases. It is 262 patients. We 98.2% we had a success rate. There are some complications with a coronary perforation, 5 cases managed with cover stent, and we never had death at that point of time in the cath lab or anywhere. A cath lab or immediately after procedure, we could manage with a cover stent. And out of these 4 cases, it was little oversized. Oversized open NC balloon. So open NC balloon, you need to be very careful. So you have to post kind of stent. It should be 1:1. And if you want to pre-dilate, always better to take a 0.5 millimeter less, because you have to go to high pressure. Although it says that balloon maintain the diameter, but still we need to be very careful. Device failure with a shaft rupture at 40 atmosphere before there's a leak in the shaft, and balloon rupture we had at 38 atmosphere. Mace in the hospital plus 90-day 4 cardiac death we had this, and 4 non-cardiac death. You can see there's a rupture of the shaft here at the 40 meters. You can see the jet is coming from the shaft at the balloon. Balloon is here, this junction. This sometimes it can happen. And this is one case where we had a kind of rupture of the coronary. You can see that the post dilatation basically. The post dilatation there is a rupture here. Here you can see that coronary perforation. So we kept the balloon there because once you leave the balloon, there's a torrential, kind of, bleeding because it's a very high pressure situation. Once there's a rupture, that this leak will be very, very severe, not like a other balloon dilatation. So so we kept the balloon. Finally, put there's a graft master, and we could seal the block very well. You can see that after graft master, we kept the graft master such a way we didn't even jail the diagonal also. So it had good results. Of course, we need to do the pericardial tapping and all this kind of situation. Patient did well, and finally patient was discharged on 4th day. So in conclusion, open NC balloon is a safe and effective tool for lesion modification. Number one, stent expansion in calcified lesions. In our study, high success rate with acceptable complication profile. It offers a valuable strategy for fibrocalcific lesion modification and stent optimization when conventional NC balloon fails. Thank you very much. Take home, consider open NC balloon when conventional NC fails. Valuable adjunct in complex PCI, especially in the moderate to severe calcification. For lesion preparation, balloon size it should be 0.5 millimeter less than the reference vessel diameter. And post the stent dilatation, we can take a 1:1. Inflation should be slow and steady once it reaches 20 atmosphere. Thank you very much for your kind attention.
Thank you, sir. If audience has any question, they can post their question in the chat window. It will be shown to us and would be taken up gradually while during the session or at the end of the session. Parva sir, if you're okay, maybe you can take up the moderation bit and invite the next speaker. Yeah, thank you.
Yeah, thank you. Thank you very much. I think we have a next presentation by Dr. Nikhil.
Yeah. Okay.
Nikhil, you are ready?
Yeah, I'm ready.
You can please go ahead. Thank you.
Can you see my screen?
Yeah, we can see that.
Yes, sir.
Yeah, so I think we'll take it on from there. And I think that was a wonderful series presented by Dr. Barua. And in the same context, we still talking about the super high pressure balloon, which is the OP-NC in lesion preparation. So this is an angiogram. These are not my this is not my case, but then it's a good case for illustration. So now pay attention to the right coronary. It's a awkward. It's an ostial right coronary. It is a calcific ostial right coronary, very awkward angle, and it's a kind of a takeoff which is not the usual. So now in this situation, what do you do? So that's the reason one chose this case. So you have an ostial LAD with a kind of tortuosity. It's so here, if you look at the angiographic RCA, so this is what I was trying to demonstrate, and there is angiographic calcium as well. So the challenge in this case, one of course is the guide support. One is a very poor guide support because it's an ostial lesion, and one cannot get a guide to sit in the ostium. Second is the heavily calcific RCA ostium. And third is a highly tortuous RCA. So what are the options to debulk ostial calcium? One, of course, we have an OP-NC balloon, which is the topic of discussion today. We have rotablation, which is usually my go-to option for calcium modification. And of course, you have the IVL balloon. It didn't show here. So difficulties for rotablation in this calcific osteal. It's very impossible to engage the guide catheter into the RCA coaxially. And then if it's very difficult to keep the guide catheter coaxial to the RCA in the aorta, we have a lot of wire bias issues because of the tortuosity. So the wire bias related complications we are all aware of. And if you take the burr, especially a large burr, into the guide catheter, you have a possibility of a guide catheter tip damage. So in this case, this whisper wire was crossed with the help of a Nick nano balloon. One sec. Yes. And pre-dilatation was tried with a 1.510 OPNNC balloon at 35 atmospheres, and the balloon ruptured. So again, this was a 2.2013 NC balloon. So pre-IVUS, again, we saw that we do not have a very good dilatation. The second wire, which is the Fielder XT, was crossed. And a pre-dilatation now was done with a 310 OPNNC balloon at 35 atmospheres. And subsequently, a 4x16 everolimus eluting stent was deployed. And a post-IVUS followed by the stent deployment. This is what we have, and we needed some post-dilatation. This is done by a 4.12, an osteal LAD. There was another stent deployed at the osteal RCA with a 412 everolimus stent. So we used two stents because of the tortuosity. And the post-dilatation was done with a 4.8 NC balloon with an excellent result angiographically as well as on IVUS. So this was just a case which was shown to start the discussion about the OPNNC balloon. So this was the pre-result, and this was an excellent final result. So of course, this has already been shown, and OPNNC is it's been used in about almost a lakh patients worldwide. It's a high-pressure, non-compliant coronary balloon designed for complex coronary interventions, especially in treating in-stent restenosis, severely calcified lesions, like Dr. Barua showed previously. And unlike PTCA balloons, an OPNNC can withstand super high inflation pressures with a rated burst pressure of 35. We've gone up to even 50 atmospheres very carefully in a lot of cases. It's a unique twin-wall design and can therefore withstand high pressures without, kind of dog boning. So we have a trial called the ISAR Calc trial, which showed that in comparison with a scoring balloon, a modified balloon, they had better procedural success and better luminal diameters achieved with a super high pressure balloons as compared to a modified balloon. And so can we use a OPNNC as a primary form of debulking instead of an intravascular lithotripsy? So that is the question which comes to our mind. And so there was this trial called the Victory trial which addressed this. So it was a prospective randomized trial, and the lesion preparation was done as a one-on-one randomization with OPNNC and IVL. The key eligibility criteria were 18 years or more, eligibility to consent, uh, ischemia-related symptoms or a chronic syndrome or acute syndrome, a single de novo target lesion with calcium. So calcium could be either angiographic or by OCT, or there could be a prior attempt at PCI with inability to expand the balloon. So the OPN balloon sizing was done, which is about 0.5 millimeters smaller than the actual vessel diameter, determined by OCT. And IVL sizing was a 1:1 sizing. Oversizing, overinflating above the rated burst pressure of IVL was discouraged. The primary outcome which was studied was the stent expansion. The final stent expansion in percentage, which represents a validated and a reliable OCT parameter. Relates to lack of stent expansion relates with adverse outcomes following stent implant. We had moderate and severe lesions were almost 90%. The severely calcific lesions were almost 90%. About 40% were bifurcation lesions. So eccentric calcium was seen in about 43 to 45 patients. Nodular calcium was there in about 1/4, and the length of the stented segment was approximately 24 millimeters. The procedural characteristics in the number of devices used, if one used OPNNC, there was at least 2 devices used, while in IVL there was 1 device. And the average use of devices, OPN versus IVL, was 1.35 versus 1.04. And the primary outcome was non-inferior. I'm sorry about the contrast in this slide. Was non-inferior, with statistically significant non-inferior results. And the subgroup analysis were consistent. Safety outcomes wise, they were comparable. And secondary outcome wise also, there was comparable with no statistical difference in terms of superiority, but there was statistically consistent with the non-inferiority. So that's what leaves us with the question that based on this, what is the consensus of the House? Personally speaking, I feel that OPNNC as not as much as a primary modality for calcium modification, but it's an excellent adjunct to calcium modification strategy. Once you use it secondary to after a rota or after a good IVL, and also in patients where you have stent under expansion, so you can go up to high pressures. And it does not allow any dog boning, and I think it has a fairly decent safety profile. So that is what is my take, and I think I would love to hear what the House has to say about it.
Yeah, Dr. Nikhil, it's a wonderful presentation. Case was really challenging. I think any questions from audience or kind of participant? So, Dr. Nikhil, reason for selecting OPNNC, probably it will be easy to negotiate, isn't it, in that kind of situation where osteal calcification with a tortuosity? Is it a reason you have taken
so that was
OPNNC?
probably, this was not my case. So I picked it up because it did demonstrate that if you have a crossable lesion, it showed a very good result with an OPNNC. Personally speaking, if I was given and the lesion was balloon crossable, I would have probably used an IVL prior to to the OPNNC. We also have done a lot of osteal RCA rotablations, and the challenges, like I said, do remain. What we like to do is to use a small burr instead of a primary large burr. Test it with a 1.25 burr, and then you can up burr, or then convert to a OPN or a rotatripsy OPN, depending on the strategy you decide. But the important part is to pre-decide the strategy and not use it as a, like, for example, use the rotablation as a fallback strategy. So you must pre-decide the strategy, and the aim is if you go into battle, you must know that you're going to win the war.
I think what you have shown the IVS, it doesn't look like a very, something like a 360-degree calcification. I think it is quite, understandable why OPNNC is selected.
Yes, I
Because
think
it's not
that is maybe one of the reasons it has
very
worked so
calcified.
well.
So balloon is enough to predilate. And if you talk about balloon, in this kind of situation where your guide support is less and there is a osteal kind of disease with a tortuosity, so any balloon out of all this, calcium modifying balloon, I think this will be the easiest, to negotiate through any lesions. Because cutting balloon and scoring balloon will be really difficult to negotiate this kind of situation. So open NC balloon with a moderate calcification, I think is now quite a good balloon.
It's an excellent strategy. I agree with you
Prepare the
totally.
lesions. Yeah.
Absolutely.
Thank you very much. I think we have next presentation, super high pressure balloon in lesion preparation. No, sorry. This is mastering tough coronaries, a practical super high pressure balloon, DCB approach. Dr. Moaz, he is our international faculty.
So thank you very much for the invitation. It's a pleasure to be among this group of faculty and experienced operators from India to share our experience with the OPN balloon and DCB. I will share my slide. So 1 minute. Can you see my slides?
Not yet.
Share.
Yeah.
Now?
No, you're not able to see your slide.
Now?
Yes.
Yeah. Yeah, we can see.
So I work in Germany, in the west of Germany, a city called Essen. It's one of the high volume centers in this part of the country. We have a lot of experience with complex lesions and atherectomy devices, and of course with the OPN. I have brought some interesting cases to talk about the diversity and the use of the OPN in C balloon. I will start with one of the most common uses, ISR, which we see patients have calcification, got stents, and come later with focal ISR. And this is one of the very nice options to use the OPN C balloon. You can use the normal NC and dog boning, use also modification balloon like cutting or scoring, have the same problem. And it's very important in such cases to always downsize your balloon with 0.5, use a high pressure 35, sometimes go to 40 or even 50. And you get at the end a very nice result, and that was a DCB balloon. So this is one of the usual ones we see in our daily routine. What we actually have to work on that we don't see this patient with this one. There's a very nice paper in the JACC, state-of-the-art review for coronary under expansion. And if you look at this paper, one of the main things, if you see patients with multi-layered stents, almost the only option you have is the OPN NC balloon. You can use the IVL, but it doesn't always work, and it's actually off-label. It's not stated in the IFU. Usually we start NC and then modification balloon like cutting or scoring, but OPN either one layer or for the multi-layer stents, you don't have any option with the IVL. And if it is very severe or subtotal stenosis, maybe you have to go for atherectomy devices. So OPN, this slide you saw, it's a unique design, twin layer with high pressure, ultra high pressure, and it actually works with the concept: downsize your diameter and upsize your pressure. As you have to take care that when using this balloon, it's actually very safe. We rarely have any complication when you follow this rule: downsize your diameter and upsize your pressure. Most of these cases, we use also imaging, either IVUS or LCT. And one of the points you have to take care of this wire friction. I will come to later to this point. So when we are talking about complex cases, there's also CTO cases. So someone was tough post-CABG patient, RCA CTO segment from 2 to 3, a long CTO segment, also calcified. you can appreciate it's coming retrogradely. It wasn't an easy PCI. So we weren't able to go antegrade to reach the true lumen, so went retrogradely and was able to pass through the very distal septal branches, but the microcatheter didn't follow. So we are stuck in this position. We were able to perform a kissing wire maneuver to identify the true lumen from the antegrade, and were able at the end to wire the true lumen and to implant the first stent. But as you can appreciate, proximal to this stent, there is a severely calcified tight lesion. We had tried for the first with NC, high pressure. You see this classic dog bone effect. And after such a long procedure and trying to open this vessel antegrade or retrogradely, we will not, in such a case, the first option you try is the OPN-NC balloon. And it didn't disappoint me because it works wonderfully, and we were able to end the procedure after it. So one option would be to think about IVL or atherectomy, but I think as a first line in such lesions, in such cases, you should give it a try with the OPN-NC balloon, because most of the cases it will work very well. Here's the final result on the right side. So another very interesting case is the old lady with focal ISR. She had multiple interventions outside our center, come with ischemia and cardiac MRI. So you can appreciate the focal lesion and CX. She had also focal ISR in her LAD stents, but also an ostial LAD de novo lesion. And we had to deal with this case. So we have ischemia in both regions, and the patient has severe angina. So we started to go for first CX, then LAD. So it was an uncrossable lesion with workhorse and with normal wires. So we escalated to standard CTO wires. We're able to pass with the Fielder XTA. But at this point, nothing passed through this lesion. So had to take support of a guide extension and was able to pass with a Nick Nano balloon 0.85, upgraded it. And one of the benefits or the advantage of such balloons, it's not only for the CTO patients or CTO PCI, you can also use it in your chip cases, complex coronary cases for uncrossable lesions. So you can go up with the pressure, but you have to take care. Very high pressure can cause this wire friction. So to keep it in mind, if it happens, one of the things you can do is to trap your wire at the tip of the guide catheter and to be able to retrieve the balloon and to avoid some of the wires, like, for example, same blue or Xeon, because you get this wire friction. But if you go with a pressure higher than 35, it may happen with other wires too. So just keep it in mind. This very high pressure can cause friction and stuck on the wire. To be able to remove it, you might use trapping maneuver or to have a body wire. The easiest thing is to have a body wire. So after doing the Nick Nano and upgrading the NC with the OPN-NC, so we had DCB with Protege, and this was the end result on the RCX. So then we did a stitch procedure for the LAD, and here this focal lesion was this OCT run, and we figured out it's not only one stent, there are two, and that's why I refer to this paper. In this scenario, almost there's only the best option is the OPN one, because there's multiple stent layers. There are also materials between the stent layers, and with the IVL you get no effect at all. And if the lumen is very tight, then you can go for rotational atherectomy. But for such scenario, the use of the OPN-NC and the upgrading, you start with a small one and upgrade to a bigger balloon, is the best scenario. So, and you will come this proximal LAD lesion. It was a calcified nodule. So we decided due to this fact that this old lady had several ISR, so to treat the proximal LAD with only DCB approach after lesion preparation, and the ISR with the OPN-NC and then DCB. So these are our several dilatations on the left side. And I guess this is one of the unique or one of the situations where the protege and C balloon may have a benefit, because we have multiple stent layers. We already dilated with ultra high pressure OPN and C balloon, and to deliver the drug and at the same time have some sort of modulation on that, so to expand the stents properly. This protege NC balloon may be a good option for such scenarios. So then went for the orbital atherectomy for the proximal one due to this calcified nodule. Went for cutting an open NC balloon for this lesion. Did our OCT run, and as we saw, we didn't have any flow limiting dissections and good lumen gain. We went for protege and CDCB, and on the right side you can see the end result. And she's now feeling angina free, and she's enjoying her life. So these are the runs. So we had the lumen gain. So we see in one point you have almost 3 stent layers. To treat this scenario, it's very, very difficult. And this is on the right side. You can see the lumen gain we achieved in the LAD, no flow limiting dissections. And we had an MLA above 6. So this one about the Nick Nano, the features, it's low profile, it's an NC balloon. That means it's a little bit more robust than the competitors. It didn't rupture, or you didn't have this granuloplasty effect very quickly. In other balloons, as soon as you go up high with the pressure, the balloon ruptures and then you have to change several ones. This one has the benefits, it's more robust, it's more durable. But on the other hand, if you are aiming for a granuloplasty, you will have to go for very, very high pressure, and then this risk of the wire friction and to stick to the wire. So you have to keep in mind why you are using the balloon. If the aim is only crossing, it's a wonderful one. If it's a granuloplasty, take it in mind. If you go with very high pressure, you may have this friction. So another interesting case also for the combination of DCB and bifurcation. Patient with multiple vessel disease, RCALD and CX. He was discussed in a heart team conference and decided to go for stage PCI. So we have this bifurcation, Medina 111, calcified, a large diagonal branch, and in the mid-LAD segments were also tight lesions. So the LCR was straightforward. It was done properly. And then we thought a lot about doing this case. So we should not lose this diagonal. And we all know, and you have this experience, when the bifurcation are extremely calcified, you will face problem if you go up front for the 2-stent strategy. So we are going more for a provisional and DCP approach for the side branch. And we decided to treat this severely calcified lesion with orbital atherectomy. So we started with a diagonal branch in antegrade manner, so with only low speed. So you have only this 80,000 rotation per minute for vessels below 3.5. And to lose it, I put a Xeon blue wire in the diagonal, went with glide assist distal to the wire, and then started retrogradely with higher speed to do the LED. And this was the first result after performing the rotation atherectomy. Treated the lesion in mid-LAD with NC and then protege balloon. And the result was very nice, especially in the EVUS. I'll show you later. And I went for the jail balloon technique for this bifurcation. So I had my DOCB protege in the side branch. I was able to first apply the medicine to park it there. And if I need any sort of modification or the side branch is occluded, I can still be able to rescue it through this technique. And this is one of the benefits due to the fact that the medicine and the DCB, this protege is not mounted on the balloon. It is in these pockets in the wing seal technology. You are not under this time pressure to apply the medicine and to deliver your balloon as quick as possible to the lesion. that's a huge benefit from the protege. You have your time, you can do it. And at the same time, the deliverability of this balloon, due to the fact that the medicine is not mounted on it, is by far better than the competitors. So it's how it looks like after stenting it. We choose the lens according to the IVUS, and it was open, so we retracted now the balloon. We didn't need to do another dilatation. Important in jail balloon technique is not to implant the stent with high pressure. You implant it with nominal or below nominal. Check the side branch. If everything's fine, retrieve it, do the pot, and here's the final result after treating it acutely. And the patient had remaining RCX lesion. He came back. This is the IVUS run. It was with HD IVUS. We didn't have relevant dissection in the mid LED. We had a lumen gain after we compared it pre and post. And the stent expansion was very good with a very good MSA. So the result was very good for the first intervention. And the patient came back for a follow-up and to get the PCI of his RCX. And this is how the LED looked like. And you can appreciate the lumen gain in the mid-segment after treating it with DCB-only approach, and how the diagonal looks good without stent, and the good result in the LED. So in the last case, also one of the interesting cases, we know the recent study solution. It works also in de novo lesion. And we all hate this scenario, this type of ostial RCX lesion. It's tight, the angle is not that optimum, and some patients come back with stent fracture and ISR. And this is one of the lesions where I was trying to upfront think of a different approach, like doing for only DCB approach without stenting these lesions. And for such lesions, you have to have the plaque modification tools in your cath lab. One of them is the OPNNC balloon, because you can get adequate plaque modification. Most of the cases are calcium nodules. So we went for the EVUS, didn't pass through the first ones. We went for orbital atherectomy, also antegradely. And this is one of also the benefits of the orbital atherectomy, to do this retrograde with high speed to achieve this most sanding effect of the nodules. Then went for OPNC balloon, high pressure cutting balloon, DCB protege, and checked it with IVUS, and this was the end result at the end. So it's wonderful, without any stent, without any metal, and to avoid that this patient come back with ISR or stent fracture and to have to apply a second stent in it. So thank you for your attention.
Thank you, Dr. Moaz. It's a great presentation with varieties of difficult cases where you have tactfully utilize the open and balloon. Especially, I'm very much impressed with the way you utilize for the restenosis, ISR. I think this is one area where open and balloon is very, very useful, because inside the stand, you can go to very, very high pressure. You can really, redeploy the stand or followed by DCB. I think this is one of the very excellent strategy for ISR. One best, very, very much interesting case you have shown is the jail, DCB balloon. This is very interesting. I think we should learn this particular case that in a calcified lesions you can jail a balloon, but at the same time, as you told that if you jail a balloon, you should not go to should not deploy the stand at very high pressure. That you need to be very careful, especially when there is a calcification, isn't it? So that's very important to remember that, because if you go to very high pressure, stent implantation, probably balloon might get kind of stuck also. This is one of the good technique even many people apply when there is a chance that maybe that the diagonal branch or side branch might get closed. So this is some kind of protection, which is very, very useful technique. Thank you very much, Dr. Moaz. Any kind of comment from?
Dr. Moaz actually is a very nice presentation and a very informative. The only thing what I want to convey is in the thick concentric calcific lesions as well as ISRs, underexpanded especially, and thick fibrous tissue and fibrocalcific, this is very useful. But eccentric calcium and calcific nodules, how far this is effective in lesion preparation? And second important is any concern of the osteal side branches lesions when you are preparing. And fibrous tissue, it is useful, but predominant eccentric calcium and nodules, it has a limitation of perforations and all this because of unequal pressure transmission. So, what is your experience regarding the ideal indications of OPN in thick concentric calcium and ISR, as well as the underexpanded stent? Apart from these, any other extended indications of OPN without any complications? Safety OPN, I want your opinion.
So one of the most important issues when using your OPN balloon is the approach to go for DCB only approach is different from stent approach. So if you are talking about ISR, we look about the lumen and not the actual vessel. We have to appreciate how big is our vessel and how big is our lumen, and to be realistic. So in one of the cases I saw with the OCT, we had in one 3 stent layers. So you will have here a human gain, but in no way you will get the same one as a vessel. So that's why we have to start now to think about such approach before implanting our stents. Actually, you have to use your OPN and this tools in de novo lesions, because if we implant stents with a not optimally prepared vessel, you will end up, this patient will end up coming later with ISR, and you will face these problems. So the one of the safety issues in OPN, what the people use standard is one-to-one dilatation. But if you do it in OPN, especially in the eccentric ones or the nodules, it will end up with perforation. And we have this standard in our center, never use one-to-one sizing, at least 0.5, in some cases 1.0 millimeter less, and go up with pressure until 50 even. So it's the pressure is not the problem. The sizing, this one-to-one sizing in this calcified vessels is a big problem. In fibrocalcified or mainly fibrotic tissue, we use modification balloon. Like I love to use cutting more than scoring. Because cutting, the dissections you induce with cutting, they are longitudinal, and the flow is the vessel flow. So even if you have hematoma, you don't have the spiral dissections, either retrogradely or antegradely. They are more controlled with a cutting balloon. And if you need to give more modification and to make more dilatation with the OPN, the OPN NC is here a very good option. So it depends on your strategy. We are going more now towards metal-free or less stents or hybrid approach, like the one with the bifurcation, to treat the side branch with DCB, the main branch with stent, and the possible targets for bypass. We treat them also with DCB. This is also one of the, if we have any potential target for bypass for cabbage, we start to think about using DCB approach, imaging guided, to save this option for later.
Any issues with abrupt reclosure or abrupt closure following a OPN and a DCB, or a kind of like what used to do happen with the plain balloon angioplasty era?
As all these cases, we perform them with imaging, either OCT, or we have the high definition IVUS from Insight LifeTech and from Boston. We have both. And the one from Insight LifeTech is actually, from the quality, is very, very good. So you can see the dissections. You can see how long is the flap, the direction of the flap. Is it a retrograde flap? Is it an antegrade flap? You can see the hematome, and then you can incide accordingly. You have to rotate your vector in the IVUS to see the whole vessel in all directions. And if I see hematome or an antegrade flap, there is a little bit long, there's a risk here for abrupt closure, and it will end up with a stent. But it's not a bailout, or it's not a disadvantage of the approach. We saw in the study, 80%, we participated also in solution, 80% ended up without stent. So if you can, and 20% you had to implant it, but it was not a failure. It's the nature of the disease. So you start your approach, you do a proper plaque modification, you use modification balloon. If you have a very good lumen gain with a stenosis less than 30%, no recoil, no flow limiting dissection, it's very feasible to treat it with CCB. But imaging guided is very important because without imaging, it may end up with fatal outcomes.
Thank you very much, Dr. Moose. I think imaging is very important. That's the most important message we should learn, all of us. Because of time, I think we should go to the next presentation. This is the right pressure or right side, achieving MLA through SHP high pressure coronary balloons. Dr. Rajagopal.
Dr. Rajagopal, I think you are speaking on mute, sir. You need to unmute.
Can you see my screen?
Yeah, we can see.
Yes, sir. Thanks everyone for this wonderful meeting, and this previous speaker was really has put it really nice, and I have two cases where we didn't intend to use the OpenNC, but ended up using it due to say overlooking of a lot of things what in an emergency. It's a middle-aged male diabetic acute antivolemic RCA CTO. LAD is having a tight lesion, heavily calcific. It was quite sure that it was not an easy thing to do. So we went ahead. This is the RCA CTO. So plain balloon angioplasty produced some flow. We were able to get a stent across and expand it. So, but once the stent opened up, we found out that there is a very tight lesion just at the distal edge. It was not allowing anything to go inside. We tried a couple of non-compliant balloons. Nothing went in. Then we decided to, this was after the proximal dilation, then we took in the open NC 2.7510, and this opened up quite well at 35 atmospheres pressure. The final result was quite gratifying. It's quite a nicely expanded stent. Of course, we didn't have the IVUS at the time to go through. So the second case is an elderly lady with post PTCI to LAD, recurrent unstable angina, de novo RCA lesion. The RCA lesion appeared very innocent. It was a distal, a mid RCA type lesion. So we went ahead thinking that it will be a soft lesion, but it was a really tough one, and it needed it was like a CTO. We needed a Gaia 2 to cross over. Then the rest of the dilatation was concentrated on the lesion. So we thought we had achieved a very good result after the stent. So we sent the patient back home. It was dilated fully. Only thing is we did not do an IVUS then. It appeared like a good result, and we left it. Then the patient came back after a couple of days, for 5 days, with severe chest pain again. You can see that the proximal end of the stent, there's a underexpanded with some sort of a flap there. Then took the patient again, we found out that nothing was crossing in. There was a very, very tight lesion of the means the underexpanded portion of the stent. So we tried to get in, nothing went inside, nothing opened up. This was the NC balloons. After a small NC balloon which refused to open. This was a 2.510. Then 2.5. We took a 2.75 open NC. Somewhat it gave up. There was some dog boning, but it gave up. Then we took a 310. It was a 3.5 vessel. So we took a 310, expanded it well. It opened up quite well. Then post-dilated with, you can see the expansion there. We post-dilated it with 3.5 NC, and the final result was quite good, and patient was quite relieved, getting asymptomatic, and it's 18 months till then. So means many times open NC achieves what we don't expect. Means pre-dilatation, we expect a lot of things, and we can use the open NC upfront before the stent. But many times after the stent goes in, there are a lot of unexpanded portions of a stent, and open NC is a good option for that. And that's all my talk. Thank you for your attention.
Thank you, Dr. Radhagopal. I think a really excellent case. Second case now shows that if you leave a stent under expanded, patient will come back very fast. So I think this kind of situation, this is the only balloon probably which will help you really, because going inside the stent, under expanded stent in other balloons is not easy, you know. So open NC balloon, you can go inside and go to very high pressure, and you can fix the stent. That is a beautiful scenario. Many a time we have seen this kind of scenario. I think open NC saved us in a particular day. But one thing we should tell that although we should understand that when you do a calcified lesion, always do it before putting a stent. That's the most important thing. So open NC would have been better before you. Yeah,
right.
Yeah, that is always
Proximal
important.
calcium was not say very much evident, so we overlooked that because it was an
Exactly.
ACS.
Yeah, it happens.
Right.
It happens. Thank you very much.
Right.
Thank you. I think last talk, Dr. Kapadi, I think he's going to show us the DCB in this kind of situation with your open NC balloon. Dr. Kapadi.
Please, sir. Sure. Stop share. Previous, we have to stop share. 1 minute. I'm opening my. Can we stop share yours in? Somebody.
So you can attempt to share now. Nobody's sharing their screen. You can attempt to share, sir.
Here it is unable to open this one. Choose what to share with AppJom as it is coming.
You can simply click on the window where your presentation is open, and it will show up.
It is actually mine is I kept in this one, and normally it should display, but it is not showing that. Choose what to share the open Zoom. It is coming like that. Okay. Can this one sharing? It is. Yours is coming actually. I'm unable to understand these. My can you see my this one?
No,
So
we are not able to see.
That's why I'm. No, here it came actually. 1 minute. This you have to stop share somehow. Yours is coming instead of.
So once you click on share screen, just simply go to window. You will see a second tab window. Go to window, and
Window,
then
I'm going window. I'm going the window, but it is displaying OPN and it is just screen.
Got it. So there's if you have a separate window where your presentation is open, you can simply click on that window, and then click on share. It will share it.
No, correct. Actually, once I share screen, what happens is my minimizer, this one has to display on the screen. It is unable to display my slide presentation.
Sir, I'm.
Now, can you see? Can you see now? No.
No.
No, we cannot see your screen.
You can
So
share and select your presentation.
Okay. What is the thing? How can I?
If you share the entire screen, then it might come.
Entire screen it is displaying, and Chrome tab I have to open, and our window. window, it is unable to open
Entire
the
screen, and then you can
reversible
sort of
display.
minimize this particular the zoom part. Then you'll see it at the bottom. Minimize or reduce the size of the zoom screen.
And I've dropped my email ID in the chat. If you can quickly send me a presentation, I can share it from my side. If yeah, if you're facing challenge, yeah, you can just quickly send me a presentation.
Actually, it should display on this one, but I'm unable to display the. Somehow, once you share, I do not know the app and all these things. Your screen is only, it is shared actually here. That is a peculiarity actually here.
Maybe you can minimize that screen.
I have to minimize the screen. 1 minute.
Minimize and share your content.
No, Dr. Baru.
I don't think he's shared the screen at all, because when I press my share button, then it says override. That is not showing. Then there's no screen being shared by anybody so far, as of now.
That's why I'm facing difficulties also.
So I think one more thing is that once you say share screen, and there's a button at the bottom in green which says share again. Maybe you're not pressing that button.
1 minute,
Once you
just
say
I
share
will do
screen
that.
once you say share screen on the top, there's another button in the middle at the bottom which says share. Maybe you have to
Just
press
1
that
minute.
again.
1 minute, I am doing. Here I am doing share screen. Then what in the bottom?
Then there's another button in the middle at the bottom in green which says share.
Green,
Yes.
the same thing I'm doing. Actually, share
You've done
screen.
all that. Okay. Then
Then
I
it
don't
is
know.
going cancel. Only instead of my presentation, it is getting entire screen like that. It is coming in the window. Even I press the windows, it is not displaying. So some technical difficulties I'm facing.
You can
Actually,
just email it or WhatsApp it.
Can you see a PowerPoint anywhere?
that's why I'm telling. I minimize my PowerPoint. It is unable to display on my PowerPoint here.
Sir, can you quickly share your
No,
presentation
go to PowerPoint and
on the
select your
email ID which
presentation.
I've mentioned in the chat?
Or what another way you can do it is just come out of the meeting, maximize your PowerPoint, and then come back into the meeting. Maybe
Okay,
that. Once you go out of the meeting, you'll be able to see your PowerPoint. Then you can maximize the PowerPoint and come back into the meeting and share screen.
1 minute, I'm doing. Yeah. 1 minute.
Just exit.
The PowerPoint is not coming display on the should that is,
No, sometimes it goes down into that, you cannot see it because your zoom is on the full screen. So if you minimize your full screen zoom, you will be able to see your PowerPoint at the bottom. Or just leave the meeting, maximize your PowerPoint, and then come back into the meeting.
in spite of also it is not coming. That's actually it is there actually.
No, you have to leave the meeting and come back. See if that works.
Okay. Again, I can rejoin. That is a better.
Yes.
Na?
Yes.
I understand now. Okay.
Maximize your PowerPoint and then come back into the meeting. Let's see if that works.
Yeah, I'm coming. Sorry for the technical difficulties I'm facing. Leaving again rejoin.
I think sir was able to log off. Let's see once he joins back. So meanwhile, I just want to share that we have 10 participants in audience. And from the question side, we have just one question, which is kind of an open question. And the question is, when do you use an OPNNC versus a cutting balloon or scoring balloon? Uh, Maybe any of the speakers could answer that, or
Yeah.
Dr. Moaz. Yeah.
Yeah.
So it depends on the pathology. Are we talking about de novo or instant? Actually, for both, the combination is the best. If you are aiming for a DCB only approach in de novo lesions, you have to use modification balloons and high pressure balloons, and at least like make a long dilatation, at least 30 seconds or more, as far as the patient's tolerated ischemia. And for ISR, it depends if you have only a stent under expansion without any neo-intima, so you don't need any cutting balloon or scoring balloon. So imaging here plays a role, or if it is visible in the angio. So the upfront OPN, if you have only a stent under expansion, if you are dealing with neo-intima and sort of a combination stent under expansion and intima hyperplasia, then you need the combination of both.
Yeah. I
Thank
think
you, Dr.
we should understand very well this OPNNC is a ultra high pressure balloon. So always we select a situation where you need to go for very high pressure. That happens when there is a kind of at least moderate to high calcification. And this is the situation where OPNNC balloon will be very, very useful. Though cutting balloon we can use, but we cannot go to very high pressure. So maybe in that kind of situation, probably this even OPNNC balloon also in additional balloon may have to use. So it is nothing like that. One particular balloon can be used in a particular situation, but one characteristic of this OPNNC balloon that you can go to very, very high pressure, unlike other balloons. So that particular quality probably can be used in certain situations.
Thank
Dr.
you.
Kapadi,
Thank you. Dr. Kapadi has joined back. Sir, are you able to share your presentation now? You please share.
It's very difficult to manage actually.
Not able to manage?
I'm facing that. Any clues and
I don't know why. Once you share, you can go to PowerPoint and click your presentation. Automatically, it should come.
That's why I'm telling. Very peculiar.
Not able to do that. I think
It's possible for you to quickly share your presentation to me. I've kept my email ID in the chat box. You could see it. Just quickly send your presentation to me. I'll share it from my side.
Something was coming.
Sir, the screen was shared. Could you please do the same step that you did earlier?
Yeah, please. I'm doing 1 minute.
Yeah. Please do that step that you did earlier, and then you can open your PPT from there. Yeah, perfect, sir. Perfect. Now you can simply go to the PowerPoint below. Yeah. Just click on that tab or window. Yeah.
No?
Perfect, sir.
It's coming.
Now? Yeah.
Thank you.
You can see.
Okay. Thank you. So I want to present. I think time is too late. OP and how it is useful in different subsets. Just I want to discuss. The first and foremost is the lesion preparation, where the lesion simply looks but very difficult actually. So the clinical history: a 75 years old male having risk factors, presenting as a chronic stable angina with inducible ischemia. The will function. The angiography lesion looks very simple of circumflex OM. 85% tight lesion was there. You can see actually there is some OM1 is a tight lesion, tubular lesion. whereas OMT is also lesion was there, and we pre-dilated with routinely with 2 into 12 millimeters balloon. You can appreciate it, and it seems as if it is dilated, but fluoroscopic it is somewhat poor quality on that day. So what we thought, we prepared the lesion. It is looking like a lesion was prepared. Then sequentially pre-dilated, but somehow it is not unable to, the lesion not prepared adequately. Then what we did is we want to take the guiding support also for the passing of the stent, unable to pass the stent. Then what we did is ultimately it is an undilatable lesion, and we have to take an stent uncrossable but balloon undilatable. In spite of the acute force, which almost 28-30 atmosphere, it did not yield. But we have taken the open NC balloon of 2.5 into 10 millimeters balloon, and then we dilated very effectively, and then the stent crossed very easily. So it is a balloon dilatable but stent uncrossable, which is a peculiar. That means lesion was not prepared properly, which can be due to a thick fibrous tissue, which we are unable to dilate the lesion. Seemingly very simple, that one. On that day, the intravascular imaging not available for finding that one. And ultimately, we put the stent and deployed. And then post dilate also we did the OPN. That is a mistake we did. So after that one, the patient has a very good, but a small, you can see intramural hematoma development, a contained perforation. You can observe on the inferior surface of the stent, there is a small cap like is there, which is a classical intramural hematoma. You can appreciate a submural hematoma. And of course, remaining branch also we dilated, and we prepared and we deployed the stent. Still, you have seen that one which healed. So it is nothing but just prior to the perforation, which is a submural hematoma, subadventitial hematoma, you can call it. And ultimately, the second branch was dilated and prepared one with a good final result. And patient was this one. So ultimately, the thing here, we use the angio NC balloons, angioscope balloon, flexomes, and very, very important is the guide where stent was uncrossable, we want to give the support. But unless the lesion was prepared adequately, the only thing the OPN did this magic of dilating the balloon. The only thing, whenever OPN lesion prepared done, but don't post and dilate with OPN. That is the lesson of the story, where the lesion preparation, it is very useful. And good fluoroscopy and cine is important, so that our intravascular imaging for adequate lesion preparation, so that we can avoid these type of post-stent complication. So this is a case two, a very peculiar. Again, the first one is in the lesion preparation, how open it is useful, and no aggressive OPN we should use after post-stent once it was prepared adequately. The second case is having patient has hypertension, hypothyroid, diabetes, present is ACS, and patient has moderate severe LV dysfunction. And here the angioplasty LAT circle was done in other different hospital. You can see the ladies already stent was done, which is underexpanded. It was left like that. Patient developed repeat MI, and then patient was stabilized with 2B3A blockers, and then patient has a stent in the circumflex was patent. And then you can see what we have is underexpanded stent is there. So is a cost prohibitive is IVL and cost effective is OPM. So ultimately, because of the cost constraint of previous two admissions, we have chosen OPM NC balloon initially for making the way, as beautifully demonstrated by the previous operator. Once it is underexpanded stent, sometimes routine balloon is also difficult to cross, especially OPM. which is a little bit bulky. So we, as a part of preparation, 2 into 12 NC balloon AccuForce was taken with 26 atmospheres to make the way for the open entry. And then you can see, after preparation with the balloon AccuForce, then we have taken the 2.75 because the stent deployed is 2.75 into 28 millimeters balloon. So we have taken the NC balloon 2.12 AccuForce almost 24 atmospheres. We have dilated. You can see still waste is there. Then after preparation for the open NC, we have taken 3 into 10 balloon with 34 to 40 atmospheres. Then the underexpanded stent is adequately, we can able to open the stent in the heavily calcific lesion, which it was done. Now you see underexpanded stent, how it beautifully expanded open NC. This I think this is one of the indications every operator has shown where underexpanded previously deployed stent. If you want to do with cost-effective procedure, the open NC plays a significant role compared to the IVL. And IVL and OPNs are a complementary in this type of the heavily calcific underexpanded stents. Then the OCT is showing a very good expansion. You can appreciate this one. And this is the final result. So here the open NC is for underexpanded stent is very, very useful. I think major operators show this type of results. Then this is another very interesting finding where the limitations of IVL is compensated by means of OPN. So this is a patient of 72 years old male presenting an anstomy with ischemia into LVF. Patient having a risk factors with moderate LV dysfunction and having a triple vessel disease. You can appreciate this is a baseline angiogram where the distal left main with and osteoproximal and extending up to mid segment of LAD, the calcific tram track calcium with a tight lesion with the TIMI 1 to 2 flows in the LAD, you can appreciate. And what we did is here, the lesion, you can cross it with a whisper wire and then ultimately with a microcatheter exchange it to the Viper wire. And then after that one, we did the orbital for the lesion preparation because of the heavy calcium. So after orbital was done, sanding is done, then we pre-dilated with a 2.5 to 12 millimeters NC balloon, that is AccuForce. And then after 2.5 to 12 balloon done, still it is some areas of waste was there. With even 3 millimeters also we upgraded. Then we have taken the IVL shock wave 3 to 12 millimeters and then give 80 cycles were done with a mid to arterial lady. But here the limitation is because we can't take 3.5 because left main is very large size, because 3.5 we can't take the IVL for the left main. So that is a limitation here. And then you can appreciate here still some waste was there. You can appreciate that previous operator shown in spite of the IVL some waste sometimes will persist because the undersize of IVL. And here the even IVL we extended the pulses to the proximal LAD. You can appreciate the waste. In spite of the pulses also still waste is that Dr. Barwa has beautifully demonstrated in his case. Then we did the NC balloon at the bottom preparation. Even at for 20 atmospheres, still waste is there. Of course, the distal stent, it was a preparation, distal lesion prepared. We put the distal stent. Then after IVL of proximal, still proximal lesion was not properly prepared. Then we have covered LAT left main 3.5 to 33 with the overlap distal stent. And here we want to deal, because of the underexpanded the stent, we did with the NC balloon followed by OPN balloon. So where the IV limitations, sometimes the two different IVLs of the different size we can't, because of long segment, sometimes left main, where you have to require a large size IVL, we become undersized, where the OPN scores over that one, which become complementary to the IVL. And then that underexpanded lesions and underexpanded stents, we can able to dilate. Then ultimately part was done with 3.5 to 12 NC balloon, and then 4 NC balloon, and with these are very good final results with the TIMI 3 flows. So like that, for the OPN, it is a complementary to IVL. Once the different sizes of IVL, which is very difficult to bear the burden, cost burden, the OPN plays a significant role synergistic to the IVL in good lesion preparation at the same time, but a good stent expansion and underexpansion to the left main. Then this is the another important, very interesting case where sometimes everybody will face, that is the hypertension patient diabetic with STEMI, and where the time is the muscle. And here you can appreciate the moderate RCA disease, where the LAD is the stump occlusion with thrombotic. Then this is the baseline CAG, where you can appreciate the circ lesion was there, moderate lesion, RCA mild disease was there, and heavily calcific LAD presenting as STEMI with total occlusion. And ultimately it was a wide LAD, and then 2 into 10 millimeter speed dilatation was done to establish the flow. Here the patient has severe gradient hypotension, the procedure requiring the TPA as well as the ABP support. So then immediately we did the lesion preparation, because the calcific thrombotic angioma, ideally laser is the useful in this given case because of the combination of calcium and thrombus, but it was absent at that time. So we did the angiosculpt as a part of the lesion preparation. Once the TIMI flow is established, then we prepared the after this we deployed the drug-eluting stent 3 to 33, and then high pressure dilatation with AccuForce was done with 3 into 12 atmospheres, 3 into 12 mm NC balloon with 26 to 28 atmospheres. You can appreciate that where there is a heavy deep calcium is there with the stent boost, still underexpanded stent is there. So at that time we also exhausted, then we shifted the patient, and then subsequently on third day we again shifted the patient, and then here very important, we dilated with OP and NC balloon with the guideline that support to facilitate the IVL entry. So here it is very useful, because through this stent it is difficult to pass the IVL, which is a bulky. With the help of the guideliner, we passed the OPN and prepared that lesion, and then subsequently passed the IVL 3 to 12 millimeters. Almost 8 cycles was delivered. And then you can appreciate how pre and post IVL, that indentation of, because caused by the heavy deep calcium, almost subsided after complementary of OPN and IVL combination combo. And then this is the final result you can appreciate with a very good stent expansion with a combo of IVL and OPN. So these are the, sometimes we face a lot of these difficulties in calcified, and everybody face the same problems. And OPN balloon is very, very useful, especially ultra high pressure balloon dilatation, along with the IVL in stent underexpanded stents, and then severe fibrocalcific ISRs. And then the other important thing is lesion preparation and especially whenever you are using the OPN, the safety of OPN always is what I observed is very important is ultimately thick concentric calcium. After doing the imaging in calcific lesions, 0.5 millimeter undersize IVL you can take, and ultimately you can crack the calcium and you avoid the nodules as well the eccentric calcium for a safety of OPN. Most important, what I observed. So I think ultimately the OPN, it is synergistic IVL for underexpanded stents and fibrocalcific lesions, and thick concentric calcium as I said, OPN is a very powerful tool for lesion preparation. Thank you very much.
Thank you, Dr. Kapadi. I think excellent demonstration of the cases in where OpenNC become very, very useful. If you really do the complex PCI with the calcified lesions, I think without OPNC is very difficult, either as a solo or as a, in a complementary kind of tool. This is most of the time is really required and very, very useful in a cath lab. Any comment from panelists?
I have one question. If the results of victory trial did change your approach in the cath lab, because we used to combine rota with IVL, but now we know economically and also from the victory trial, either to go up front with OPN or to, if you combine with atherectomy devices, we tend now to combine it more with OPN than with IVL, because also it's a reimbursement issue. The IVL in Germany, if you combine it with atherectomy, you will not get paid for both. You get only for the whole procedure once. So if we combine, we tend to combine either OPN and then go for IVL if needed. It's actually rare. Or if we combine with atherectomy, we go with OPN before we go for IVL.
Dr. Mons, actually here I want to give my inputs. Actually, to be frank, for the superficial calcium, protruding calcium, the rotablator as well as the laser are very useful tools. Whereas for the deeper calcium, especially subadventitial calcium, deep mural calcium, I think the orbital, OPN, and IVLs are very powerful tools. I think you have combined the synergistic after imaging of the distribution of the calcium. I think we have to, they are complementary. We have to intelligently select this type of device synergy or isolated tools depending upon the distribution of the calcium with its severity.
Yeah, I think any kind of grade of calcification, if you have a OPN and IVL, most of the time you can manage as long as you can negotiate the balloon. So we have different techniques of negotiating balloon, unless really, really very tight and not able to pass even small balloon. I think if you Godzilla or guideliner or some extension catheter, most of the balloon can be negotiated. In that case, most of the calcified lesions, I feel if you give me an open NC balloon IVL, can be, I think, managed. That is, so if you really have a kind of insurance or government recommendation to use IVL and OPN NC balloon, most of the calcified lesion can be managed with that, these two tools.
Yeah, Dr. Barua, especially what I observed is with IVL, you fracture the calcium and redistribute the calcium with OPL. Usually, especially what I observed is whenever we use the out of NC balloons, I have seen the AccuForce is the one which is
high pressure.
Yes, out of all the NC balloons I have observed of all varieties, at 24 to 28 should yield. But sometimes we have seen even with the 24, 26 AccuForce, which you can't expand the stent, but the OPN 16 atmospheres it become because of its AA technology. And I have seen these magics actually. Even 28 atmospheres AccuForce, it can't. But OPN 16 atmospheres, that indentation disappearing and
Exactly. I think this is very excellent observation. Maybe open NC 15 atmosphere will be equivalent to 24 atmosphere of the other balloon. I think that is because of the stiffer wall and kind of amount of pressure it can give to the wall. And so I think at a time probably effective pressure, final pressure will be very high with the open NC balloon rather than other balloon. I think that is the reason probably we can get very early effect of the open NC balloon.
Can I?
It's a nice observation. I think that we have observed in calcified lesions.
Yeah.
Can I put?
Any other tips and tricks, Dr. Mose, you can give regarding OPN? Dr. Nikhil Kumar.
No, I prefer. I was
Dr. Nikhil?
that, my preferred strategy is not an IVL to start with, especially if it's a long lesion. It's a kind of very diffusely diseased, severely calcific lesions. I mean, I find IVL very difficult to negotiate. One. Secondly, it gives since the lesion is very long, you have to give pulses right down. You may not be one balloon may not be adequate. And thirdly, the patient becomes very ischemic during this IVL pulses.
Yeah.
My preferred strategy, if you have a lesion like that, is a rotablation. And it's so easy to go in if you have a very long lesion, a lot of plaque burden, go in with a smaller burden. I mean, there's no problem upburring, and I don't think the insurance really so we actually keep a couple of used burrs up our sleeve, which very rarely we use anything again. But then a used burr is a very useful thing to happen. You can use if it's a very bad lesion, use a new 1.25 or a 1.5, and then upbur to a 1.75 or a 2.0. So I think upburring with the rota, I find it very easy. When you finish with the rotablation, you have clean channels, you have no dissections, you have
Yes.
easy deliverability of most of your hardware. And OPNNC is a very good tool as an adjunct to rotablation. This is what my take on the whole thing is. Primary
Yes.
OPN use, I'm not very conversant with, but then yes, I've heard so much good about the OP and DEB idea, and I'm very tempted to try it.
I think this is a good comment from Dr. Nikhil. I think OpenNC is always a very useful tool, adjunctive tool in the other. This one after even rotablation or IVL. This is on the one of the very useful tool in a calcified lesions. Now what Dr. Mose told that they have only if you give IVL they can use OPN or there's a kind of the government regulations or something he was telling. So that's the reason probably. I think definitely no doubt about that. Rotablation is one of the best tool to make your life comfortable in cath lab for a calcified lesion. No doubt about that. Yeah.
So it's very important, Dr. Barwa, you told, because Dr. Nikhil told long lesions, heavy calcium, we do not know the spicules and nodules which may cause rupture of the IVL balloons. We have seen so many times.
Yes,
So what you do is you soften it by means of rotor orbital. Then you fracture it, the deeper calcium with IVL. Then the IVL rupture chances will be reduced. If you use primary IVL, one is deliverability, second one is the ruptures. These two are seen, especially long, heavily calcific lesions, because of the spicules, which are unpickable.
Yeah, I think once somebody familiar with the rota, I think in a calcified lesion always we prefer to go for the attractive rather than any other tool. Beginning, isn't it? So it is
Also,
your
a lot
life
of
becomes
times
so
when we have
comfortable.
CTOs which we have wire crosses where your balloon does not cross, or like you said balloon crossable, stent not crossable. I think a rotablation is a very useful tool there also. And a lot of times when you have a a CTO wire which is crossed, you take a very good microcatheter, jam it into the the proximal cap, and then you can most of the times you can pass a rotor wire through, and then
most of
once
the
your
time.
wire is through, then life is very simple.
Yes, by tipping technique, yes.
A Nick Nano, of course, is another very useful balloon for a CTO.
Balloon,
I find it, when nothing works, it does.
True.
Thank you very much. I think we had a good discussion today about calcified lesions, specifically balloon which can go to very high pressure All of us know that calcified lesions always challenge in cath lab, and we need a tool. Either we can ablate the lesions, or we can fracture the calcium, or we can modify the lesion going to a very high pressure. I think the open NC balloon comes in this particular situation where you can prepare the lesions. If you want, suppose moderately, calcified lesion can be very well prepared with the open NC balloon. Of course, highly calcified or heavy calcifications, I think little difficult as a primary tool, but in a moderately fibrocalcific lesion, open NC balloon can be used as the primary balloon. And most important is it can be a very adjunctive, very useful tool with associated with other tools like rotablation, IVL, or orbital atherectomy or laser, whatever it is. So it can be used post-stenting or before putting a stent after the other device is used. So this will be very useful. Without this, I think we feel really handicapped in a cath lab, especially when you use you do a lot of calcified lesions, complex lesion angioplasty. So this is a good tool. I think only one thing for the young cardiologists, you should be a little careful. You should always kind of undersize for a primary preparation of the lesion. Always in a 2.3 millimeter artery, take a 2.5 millimeter balloon so that you can go to very high pressure. So you can test the lesions there, how it is behaving, and you can get a room for the other devices. And of course, post-stenting, you can go from 1:1. You can go to very high pressure 1:1. So you don't have to worry. But still, we have to size should be proper. So always go with a distal reference vessel diameter, and always try to have a imaging in a calcified lesion so that you can perfectly select the size of the open NC balloon. In that case, I think there should not be any complication. This balloon is very safe balloon. It is very useful in calcified lesions. With this comment, I think I'll give to Mr. Ronak, and I'm thankful to TransLumina for arranging this meeting. And Dr. Ronak.
Thank you, sir. Thank you, Dr. Barua, for that great moderation and also presenting your TCT lecture. So first and foremost, our sincere gratitude to our esteemed international faculty, Dr. Moaz El-Shabarasi, for sharing his invaluable insights on mastering tough coronaries with the super high pressure balloon DCB approach and showing his interesting cases. Dr. D.K. Barua, sir, again, thank you so much for steering the session seamlessly and also presenting your real-world single-center experience on treatment of calcified lesion using OPNNC. We are deeply grateful to Dr. Nikhil Kumar, sir, for elaborating the victory trial findings and highlighting the evolving role of super high-pressure balloons, OPNNC, in lesion preparation. And our again sincere appreciation to Dr. Rajagopal sir for his practical insights on achieving optimal MLA through some of his cases using pre-dilatation. Last but not the least, thank you so much, Dr. Kapardi sir, for those interesting questions and sharing your interesting cases of OPN used in both pre and post dilatation. We also extend our gratitude to all the attending interventional cardiologists for your active participation. And together, let's have this commitment to advancing patient outcomes in complex PCI with use of OPN. And finally, on behalf of TransLumina team, I thank you once again for being part of OPN Colloquium. And we look forward to welcoming you to all our future academic initiatives. Have a wonderful evening ahead. Thank you so much.
Thank you very much.
Thank you, Dr.
Thank
Good
you.
evening, Dr. Barwa Nikhil.
Thank you. Thank you, Dr. Kapadi, Dr. Nikhil, Dr. Moaz, and Dr. Gopal. Thank you very much.
Thanks a lot for having me and for the invitation. It was a pleasure to be among you. Thank you.
Thank you very much. Good night.